I'd like to introduce Dr. Trescot now. She is an interventional pain specialist with too many accolades to go into, and still have time for questions and for the session. Dr. Trescot has this wonderful ability to suss out what's going on and to be able to relate that in a way that people can understand. I don't know, I'll stop. I can sing your praises forever. Dr. Trescot has absolutely helped me heal, has helped countless other people to heal all around the world. And so I will just leave it up to you, Dr. Trescot.
Well, thank you very much, Annette. It was it has been just very gratifying seeing where you were and where you've come from over the last couple of years. So you've come a long way, baby. So Annette asked me to talk about cervicalgia, or pain in the neck, and this was originally going to be supposed to be a DO lecture about osteopathic manipulation therapy. And what I did instead was looked at trying to get it to do a little bit more from an interventional pain practice. So as Annette said, I practice there in Alaska, and Eagle River and in Soldotna. I'm a lot of formers, a former professor, a former president of the American Society of Interventional Pain Physicians. I've been the director of fellowship programs, and I'm currently the chief medical officer of a stimulator company called StimWave, which we won't be discussing at this lecture. So I wanted to talk a little bit about pain generators in the neck, a little bit about history and physical, some of the tests that we do, and some of the investigations and the treatments that are involved in that. So we're going to start out with a little bit of a case history. A 45-year-old man with neck pain after a motor vehicle accident. The MVA was 6 months ago. He was rear-ended and he hit the steering wheel. He complains of occipital headaches and pain with turning his head left or right, and complains of ringing in his ears, dizziness with decreased hearing. So one of the things that is key about this, I think, is this idea of 6 months. There was a big argument for many years that people after car accidents got better with green poultice. In other words, if they got money, which was the green, and you put it on those wounds, the poultice, and all of a sudden, magically, they would get better. But it's a very common clinical problem, and it's got a lifetime prevalence of up to 70%. And severe neck pain will be experienced for about 10% of adults within a given year. Women, the elderly, and those who have been rear-ended motor vehicle accidents are the great risk. And refractory cases often have work dissatisfaction and psychological stressors because you see them constantly rubbing it. They can't get in, rubbing their neck. They can't get into a comfortable position. It makes them irritable. It makes stresses at work, and that leads to stresses at home, as well as stresses with their family. It's the fourth leading cause of disability behind pain, depression, and arthralgias, with an annual prevalence of about 15 to 50%. 50% of patients experience recurrences or a continuation of a pain up to a year post-occurrence. So a year later after the MVA, 50% of the patients are still having pain. And you've got an associated disability of headaches, depression, fatigue, memory loss, and the inability to concentrate. Now we've got a whole wide variety of pain generators, and we're going to try and touch on them bit by bit. Degeneration, trauma, biochemical injuries, postural sorts of things, inflammation, infection, infiltration, compression, and referred pain. From a TBI point of view, not all of these make a difference, but it is part of the differential diagnosis, and it's part of what we have to go through when we have a patient who presents with neck pain after a trauma. We know that degenerative disc disease is progressive. This is the same patient. On the left, you see in 1982, you see that the neck had a straightening, but the discs look good, and there was not much degeneration. But then just a few years later, you see the degeneration occurring, the narrowing of the disc spaces, the arthritis, the extra white along the joints, which are the facets. So these are the joints. This is the narrowing of the disc space. and a general continuation, no matter whether the patient was treated for the pain or not. In fact, you notice that this is the opening for the nerves here. See how narrow that opening has gotten when the disc space narrows down. So if you're getting this degenerative change, we have to try and figure out, just like a car that's got a bad alignment, if you hit a pothole with your car, that throws off the alignment. You get a continued or accelerated wear and tear on those joints, just like you get an accelerated wear and tear on the tires. But nobody wants to blame the car accident for things that are going on years later. So we've got the mechanical disorders of motor vehicle accidents, falls, and sports injuries. We can have strain injuries where you've sort of slept wrong the night before, or you have a prolonged abnormal head movements during work or recreation. So people who are violinists, for instance, can have persistent neck pain because of what they do for both their work, perhaps if they're professionals, or what they do for pleasure. And then you can have herniations of the disc. The nucleus pulposus is the soft center of the disc, and it can squirt out and put pressure on the nerves, and the disc material itself is very irritating. And that can either cause pain in a nerve root, or it can actually cause pressure on the spinal cord, which is called what we call, so pain going down the arm because of pressure on a nerve root is called radiculopathy, and and pressure on the spinal cord causing weakness and pain and potentially paralysis is called myelopathy. So this most commonly occurs at C5-6 and at C6-7. We also have cervical muscles, and you can think of these as the lateral tracts, which are the superficial muscles, and they can either be straight going up and down, or they can go at an angle, and we'll look at these in a second. And then you've got the medial tract, or the deep ones, that can also be straight or come at an angle. So when we look at the muscles, we have the muscles. And then we have the straight muscles coming down deep, the splenius coming at an angle, the levator coming from the edge of the scapula all the way up to the side of the neck, and then the rhomboids holding the shoulder blade in place. We have this is again the levator coming from the edge of the scapula and coming on to these areas that come that and then you have the scalene muscles, which are deep to that, and the nerves that are going out to the arm come through the scalene muscles. And then when you start looking even deeper, muscles that turn So if we talk about the vertebral bodies themselves, you've got the main portion of the body, the transverse process, and the disc. So this is coming from looking at it from the front, and then looking at it from the side, we have the facets or joints, the spinous process, which is what we feel when we run your finger up and down your spine, and then the transverse process where the nerve roots are coming out, the vertebral bodies, and the discs. Now, what's interesting is that these top two vertebral bodies look different than the others, and they have names. None of the other vertebral bodies in the rest of the body have names, but these two do. So the skull rests on the atlas. And just like the Greek god who held the world on his shoulders, this is the connection between the skull and the rest of the vertebrae. Then you have the axis, and what you don't see here is there's a piece that comes up called the odontoid or the dens. And so this rotates and this comes piercing up. So these joints also have names. None of the other facets or joints have names in the body, but this is the Atlanto occipital joint, and this is the Atlanto axial joint, or the AO and AA joints. And so you see them under x-ray. Here's what we feel when we run our fingers up and down the spine, the disc in between, the vertebral bodies here, and then the joints or facets coming off to the side, and then these transverse processes that the muscles attach to. And here you see it as well. This is C1. Looks very, very different, the atlas. And then you just begin to see a little bit of the odontoid here for C2, which is the axis, the AA joint, Atlanto axial joint, the AO joint at the base of the skull here. And they're held together by very strong ligaments. There's actually a ligament that runs from the very base of the skull, get there, the very base of the skull. This piece of bone that sticks out is called the union, or the occipital prominence. And this ligament runs all the way down to the sacrum. And then you have ligaments that hold the bones in place and that act as the capsules for the joints. If we look at it from the side, you can see just how thick this ligament is. It's one of the strongest ligaments in the body. And this is what holds the head upright and holds this whole neck into a nice inward curve. That inward curve is important because that allows the head to balance. If you ran a plumb line, or just if you look from the center of the skull down to the sacrum, it should be all in one line, but you've got these curves that allow this heavy head to be balanced on the cervical spine with this inward curve. And then we've got an outward curve in the thoracic region, which is called a kyphosis, an inward curve in the lumbar region, the lordosis, and then again, an outward curve in the tailbone or sacrum. And that combination, we talk about the S shape, and that's very important for maintaining posture. Anything that changes that puts the head forward will change the posture, but it'll also change the effective weight. So if you hold a book close to you, a 30-pound book, that's much less, that feels like 30 pounds. But if you hold that 30-pound book out in front of you, that has the equivalent of about 60 to 90 pounds because it is so, the moment arm, the physics of this make it so much more heavy. So we've got some signs and symptoms. We've got radicular pain. When pain runs into the arm along the course of a nerve, you get this sharp burning pain that radiates into the trapezius, the area between the scapula. It can run down the arm, and it will can be caused by herniated discs, foramen narrowing where the nerve root is coming out, or a fibrosis in the epidural space. And you can have weakness or these stinging sorts of pains. Then each nerve goes to a different part of the body, and that's what we call dermatomes. And each of these, from the front, from the back, and from the front and from the back, each of these goes to a different part of the body. And it looks like these were very specific, but it's kind of interesting. The patterns can vary. It depends on what the artist was smoking at the time. And so it's not cast in stone, and everybody's pattern of pain is a little bit different. We also have patterns of pain that come from where the muscle attaches onto the bone. And these are called sclerotomes. And these can cause pain going down the leg or down the arm that mimic a herniated disc. This is not, these are referred pains though. It's not unlike what we see with somebody who's having a heart attack. They might have pain or numbness going down the arm. There's nothing wrong with the arms, nerves, but the nerves that go to the heart and the nerves that go to the arm come together at the same level of the spinal column, and the brain interprets that as pain going down the arm. Doesn't make the arm pain any less, but you wouldn't get that better operating on the arm nerve. So it's important to recognize that pain going down the arm does not have to come from a herniated disc. It can come from the ligaments or the tendons, or as we'll show, the muscles. So these are some examples, as Annette showed, of myofascial pain. And these patterns of pain can mimic, again, herniated discs and pain going down the arm. So it's critical to be able to make the right diagnosis, because again, operating on a herniated disc, if that's not what's causing the pain, can't possibly make you better. So this cervical myofascial pain can be confused with myelopathy. It can be made much worse after trauma. And you can get pain in the neck, the scapula, and shoulder, and occasionally all the way down the arm to the hand. And the way you figure this out is you actually lay hands on the patient. You have to feel for these knots in the muscle, the trigger points. And it may be a problem with peripheral nerve entrapments. So a peripheral nerve that's entrapped after the nerve has left the spinal column may mimic a herniated disc as well. And they can have, you can have neck pain from degenerative joint disease and degenerative disc disease and a median or ulnar entrapment that makes it look like a radiculopathy. So if you're just looking at the MRI, that may not be enough to help you. The myelopathic pain is pressure on the spinal cord. And this is what makes the difference between a herniated disc in the neck and a herniated disc in the low back. Because the spinal cord ends about the middle of the back, in the low back, you can't put pressure on the spinal cord, but in the neck, you certainly can. And you can get a neck pain that progresses into the arms and potentially the legs. It can be very slow, very insidious. You get these clumsy hands, gait disturbances, and sexual or bladder dysfunction. So you start having I'm just such a klutz, but it may well be that their brain doesn't know where your feet are. And I'm getting a signal that my internet connection may be unstable. And so these are usually spinal cord lesions, central stenosis, or cord compression. So you could have a tumor the spinal cord. And so this would be in just below where that is, because this is a lack of blood flow to the cord. If we look at it in cross section, you see that the disc here has left very, very, very little room for the spinal cord. It's starting to now you've got a very tight aggressive degenerative disease. And that can occasionally turn into a myelopathy as well. And then you could have cancers of the cervical spine, metastases, most commonly from lung, breast, prostate, and lymphoma. And I had the unhappy task of seeing a woman who'd had neck pain in the past. It had gotten better with chiropractic manipulation. She had neck pain, and it would be sudden episodes, but it always got better with a chiropractor. And this time it hadn't. And so we'd gotten an MRI, and the MRI came in just as she was coming to see me. And it showed metastatic, as it turned out, breast cancer, that she didn't even know she had breast cancer. And so I had to tell her that her spine, that she was going to be, you know, if we couldn't get the tumor to shrink, she was going to be a quadriplegic from these, and that even though it had seemed like the same sort of neck pain she'd always had, it turned out not to be. So it can be, you've got to be very careful to make sure you don't miss that kind of a problem. And then, so the joints themselves can have a variety of patterns of pain, and they can also refer down the arm. So the things that we have to ask, was there trauma? If there was trauma, there's likely to be that it's likely that the trauma triggered something. Though sometimes what will happen is the trauma triggers the evaluation that leads to the diagnosis of something else going on. So for instance, this woman with the neck pain, she wouldn't have gotten an MRI if she hadn't had the sudden onset of neck pain. So you want to ask about stiffness, deformities, and whether they're neurologic symptoms, numbness, tingling in the hands, changes in the feeling of the face, clumsiness or weakness of the legs, bowel and bladder symptoms. And then you want to look for Other things that would be a sign that there's might be something bad going on. Fever. Is there a coronavirus? Anorexia or weight loss that may lead you to thinking more about cancer. And then do they already have arthritis? Do they already have cancer someplace else that can increase the risk of this being a metastasis? So there are a series of red flags that we have to make sure that we ask. And these red flags are not proof that there's a problem, but they're certainly concerning and need the provider to look further. So fever or chills. If somebody was healthy and they had a high velocity trauma, those are a problem, but any trauma in a patient who's osteoporotic. If they're laying down or at night, normally neck pain is worse when you're sitting up and it gets better when you're laying down. If it's worse when you're laying down, that's not a good thing. If somebody faints with it, that implies that there's a lack of blood flow to the brain, and that can be caused by compression of the carotid or vertebral arteries. If they have a history of malignancy, it's malignancy until proven otherwise. So anything that's going on with a patient who has a recent history of malignancy or a current malignancy has to be thought of as a red flag. Same sort of thing, if they've got an immunodeficiency, you want to make sure that you recognize that that immunodeficiency puts them at increased risk for infections, but also puts it at increased risk that they may not develop a fever. And if they're that immunocompromised, they may not be able to make a fever. And then if they're having problems with sexual dysfunction, because those nerves come into the spinal column at the level of the neck, you have to be very concerned that there is some sort of compression in the neck. So we ask patients to be able to do active motions. Show me, bend down, take your head back, bend your head down, side bend, rotation, and then what we call protraction and retraction. So protraction is when you stick your chin out. Retraction is when you tuck your chin back in. So you see some of the flexion, extension, side turning, and side bending maneuvers. There's some special tests, and I'm not sure how specific y'all need me to get into these. Spurlings is where you put pressure on top of the head with the neck turned to see if that replicates arm pain. Shoulder depression, you put your hand down on the shoulder and move the neck to the side to see if that puts a stretch on the nerve roots. Very similar to the shoulder abduction, which is where you throw the shoulders backwards. Does that put pressure on the scalenes? Lermet's is when a patient bends his head down and feels an electrical shock going down the legs. Hoffman's is a very interesting one. It is a released reflex. You take the finger and give it a little twitch, and if the thumb comes in, that's a sign that there is a loss of reflexes, and that's a very worrisome sign. And then Babinski's is where you scratch the foot and the toes change position. And that's also a concerning sign, something we look at when people have altered consciousness. We want to do a sensory exam to see if there's compression of the nerve roots. So each of the parts of the arm, each of those dermatomes go to a different part of the arm. So basically I will touch on both sides, the shoulder, the upper arm, the upper outer arm, the upper inner arm, the lower outer arm, the lower inner arm, the palm, and the back of the hand, looking at the thumb and index finger and the little finger. So those will tell me if there's, and I compare one side to the other at the same time to try and see if there's a difference. We're also going to look for muscle strength. Muscle weakness is usually a later sign, but if somebody's having numbness, you need to check and see if there's weakness. So I'll look at, spread the fingers out. Can you hold them apart? Put the fingers together. Can you pull them apart? Thumb and first finger together. Thumb and little finger together. Cock the wrists up. Cock the wrist down, trying to bend the wrist. Make a muscle, try and push the arm down, push the arm back. arms out to the side, pushing down on the arm or pulling up on the arm. And that'll give me an idea about strength. And again, doing it on both sides. And then I'm going to examine them for myofascial pain. And I'm looking at some very specific spots. We're looking, as Annette said, the sternocleidomastoid muscle by grabbing it. Deep to that is the scalene, the levator at the base of the shoulder blade up into the side of the neck, the trapezius out to the shoulders and down between the shoulder blades. All of these are going to be muscles that we're going to be looking at to try and see if they are referring pain to the head and the neck, or are they, and therefore maybe part of what the problem is. And then again, looking at that sclerotomal pattern, I'm feeling at the base of the skull and at the base of the levator where it attaches and along the acromioclavicular joint. Because just remember that the shoulder blade and the arm, the whole forequarter, is only held on to the body by muscles and one joint, which is the acromioclavicular joint. And then that collarbone or clavicle attaches onto the sternum, the sternoclavicular joint. So this scapula, this clavicle or collarbone is really important that's what the whole arm attaches onto to the rest of the body. The rest of it's all muscle and ligaments. So what do? When you come to see me as a patient, we make sure that you've had a white blood count and platelets with the hemoglobin and hematocrit. I'm looking for infection and for inflammation. And 100 years ago, we recognized that if you take blood and let it set to the side, blood from people who have an infection or an inflammation settles out very quickly, while normal blood doesn't. And so an ESR or SED rate is an erythrocyte sedimentation rate. We literally take a little tiny bit of tubing and fill it up with your blood and set a timer. And at the end of 1 hour, we see how far it's settled and measure that. So the SED rate of 22 means that it settled 22 centimeters in an hour. So the smaller the number, the less positive it is. The C-reactive protein, or CRP, is a protein that is released by the body in the face of cell death from inflammation. And so those two will give you an idea about inflammation or infection. Creatinine will tell you how the kidney function is. Muscle function, and then an X-ray, an MRI, and an ultrasound. And between those, you'll end up looking at the structures. If we've identified that the problem is not a surgical problem, we've tried acetaminophen and non-steroidal anti-inflammatories, then we might look at one of the tricyclic reuptake inhibitors like duloxetine, or maybe one of the gabapentinoids or gannabinoids, like I like to call them, of gabapentin or pregabalin, Lyrica, and then perhaps some muscle relaxants. So we're looking at the gabapentinoids are trying to turn down the rheostat of nerves that are sparking off. Muscle relaxers are trying to keep the muscles from going into spasm. And then the TCA and SSRI block the pain signals from getting to the brain. That's how you use norepinephrine and serotonin to, when you're meditating, when you're mindfulness, to try and block pain signals. But unfortunately, when people start hurting, they use up those serotonin and norepinephrine. And these two classes of medicine will allow that serotonin and norepinephrine to come up. So, and then we've got the interventions. And since I'm an interventional pain doctor, these are the things that I think are the most effective. And I think that way for a couple of reasons. One is that if you had a tooth that was bothering you and a mouthful of cavities, really hard to tell on an x-ray which tooth is causing the problem. So the dentist would tap on the teeth. The tooth that's tender is likely to be the one. So the physical exam can help give you an idea. But if you numb up just that one tooth and it makes the pain go away, now you know exactly which tooth is causing the problem. And so that's why I think it's a very useful tool, because it allows you a diagnosis the way the medicines don't. So we're going to talk about a couple of different kinds of therapies for interventional therapies for cervical pain, starting with myofascial pain. So once you've identified these trigger points, you can do myofascial release where you work them out. You can use the Theracane or the S-cane to try and put pressure on them. You can use the tennis balls for ischemic compression. But if I put numbing medicine in that one muscle and it makes the arm pain go away, now we know the arm pain is coming from that one muscle. And so that's one of the real advantages of these. If you were having pain going down the arm or chest pain that you thought was a heart attack, and I inject the muscle and it makes the pain go away, you know it's not your heart anymore. So from a diagnostic point of view, they're very good. The local anesthetic that you put in allows the muscle to relax. Muscles don't get good blood flow when they're contracting. And when they're not getting blood flow, they don't get oxygen. When they don't get oxygen, they make lactic acid. And that lactic acid makes the muscle cramp and burn and leads to more spasm. So it's really critical to get the muscle to relax so it can get blood flow. But if you had a dirty sponge and you dropped it in water, it's not going to get clean. You've got to squeeze, release, squeeze, release. So doing the trigger points followed by deep tissue massage or myofascial release is really much better than just the injections by themselves. And I strongly discourage the use of steroids in these trigger points because they're not inflammatory, they're ischemic. It's not that they've got infections or inflammation, they don't have enough blood flow. And so we need to restore the blood flow rather than adding steroids. If you've had good relief with multiple injections of the same muscle, a pretty isolated muscle, and it doesn't seem to be helping long-term, using a botulism toxin, a botulinum toxin might make some sense. So this is made from the botulism toxin that we get from badly prepared foods, for instance. There are multiple compounds in these toxins, but there are two sections that we pay attention to. The botulinum A, which is Botox, and botulinum B, which is Myoblock. And there's some advantages and disadvantages of them, which I won't go into, but they work by preventing the release of acetylcholine. So when you have a signal that goes, a nerve signal goes down and goes to the muscle and says, muscle, you need to contract. What makes that muscle contract is the release of acetylcholine. And then the body's very frugal. It brings back that acetylcholine and reuses it. It's making some too, but mostly it's reusing what it has. So if the Botox gets brought up instead, once it gets into the vesicle here, it then blocks the release. So you want, when you first get the injections, you want to make sure you're really working those muscles, because every time they fire, they're releasing acetylcholine and they're taking back up the Botox. If you don't do that, they fired with the little bits of movements you're making, but they're not picking up the Botox. So it's really important in my mind to really, for just a couple of minutes, work those muscles and get them exchanging the acetylcholine for, for the botulism toxin. Yeah, I'm in Florida. I'm 4 hours behind you. It's getting it's a lot, late night last night. So they're trying to get jet lagged from time changes. So here you see the face and you see the ability to frown. And so what we want to do is block that ability to frown so that it stops the entrapment of the nerves. And there you frown and not frown. Okay. So probably the most common thing we see with patients with post-traumatic neck pain is problems with the cervical facets. And each joint has nerves that go to it, and we can put numbing medicine on those nerves. And if that makes the pain go away, then we know that's where the pain's coming from. There is a lateral branch that goes to the muscles and a median branch that goes to the joint. And so when we're doing the injections that are going to the joint, they're median branch blocks, or MBBs. And so you might have heard about MBBs. If the numbing medicine made the pain go away but didn't keep it away, then it's possible to try and kill those nerves. And what we use is we use a probe that's got a little wire on the end of it, and then it's hooked up to a machine, and we run a current through and we zap the nerve, and with almost like the tip of the end heats up like a toaster wire. So that's a very common use. Excuse me. It's a very common, very commonly used for neck pain and cervical facet problems. Cervical epidural is looking at putting medicine inside the spinal column. And what that allows is to put medicine around the nerve roots as they're exiting the spinal column. Now, the danger here is right below where that needle is the spinal cord. And so we used to do these blindly, but we now do them under X-ray so we can see exactly where things are going. Right below the epidural space is the spinal fluid space. And we put numbing medicine in the spinal fluid all the time, but we use about 3 times as much numbing medicine in the epidural space as we do in the spinal fluid space. So if we were in the spinal fluid and didn't know it and gave you 3 times as much numbing medicine as you needed, you can imagine it can make you numb from the eyeballs down, and that can make it hard for you to breathe, hard for you to swallow, and make your blood pressure go down very low. So we don't like doing that. So we'll put in a small dose of local anesthetic first, a test dose. We'll put the dye in so we can see where it's going, and all of that to try and decrease the risk of getting into the spinal fluid, and even worse, to avoid getting into the spinal cord itself. Cervical discograms are much less common. The thought is you can't always tell that a disc is leaking. So if you had a tire that wasn't holding air, but you couldn't see where the problem was, you might put it underwater and then pump it up and see if you could see where the leaks were. And so a discogram does something very similar. You put a needle in the disc and then put dye in and pressurize the disc and try and see if there's any place where it leaks. And here you see that the dye should stay right here. And here is a tear, and you see the dye going into the epidural space up and down. And so this is something that would not have been picked up by MRI, but it is picked up by discogram. Goodness, gotta go get coffee. Spinal cord stimulator has been used now for almost 50 years to exchange pain for tingling. So nerves can only carry one signal at a time, and if they're busy carrying a non-painful signal, then the painful signal can't get through, which is actually why when you bang your shin, you rub it, because the rubbing blocks the pain signals. And that's what a TENS unit does, and those of y'all who've ever used a TENS unit. But those are all on the outside of the skin. So we can place an electrode inside the spinal column in that epidural space and turn it on, and that exchanges pain for tingling and can be very effective. I do apologize, goodness. Can be very effective in blocking pain signals from getting from the neck to the brain. And it's a non-destructive. This one, you see the patient's already had several surgeries and not gotten any relief from their pain. So now the idea is to try the stimulator to see if that might give pain relief instead. And then the last part I want to talk about is regenerative injection therapy. Injection, this has to do with the fact that I told you about this nice strong ligament. With trauma or with repetitive injuries, that ligament gets stretched. And when it gets stretched, that's how you get the loss of cervical lordosis, is because this ligament gets stretched. That puts a forward pressure on the disc and it makes the disc bulge back. It allows the joints to move more, which leads to degeneration. And so what you end up with is disc degeneration, facet arthropathy, and a loss of the cervical stenosis, oh, goodness gracious, I do apologize. A loss of the cervical lordosis, and now your head is, you hold your head forward because that takes up the slack. But that means then that the head, instead of weighing the equivalent of 12 pounds, now weighs the equivalent of 20 to 30 pounds. And that makes the muscles have to work harder. The muscles then trap the nerve on the back of the head and cause headaches. So all of this is caused by problems with the ligament. Regenerative injection therapy is a whole continuum of techniques that are, goodness gracious, red-eye flight last night to get to Florida. It is the ability to stimulate the body to lay down new tissue. And if you can do that, you then restore this ligament to its normal strength. The head comes back up, the inward curve, you get no more accelerated degeneration. And it's one of those few things we do that actually potentially fixes the problem. So there's a whole continuum of therapies that we can use. The oldest and the cheapest is one called Prolotherapy. And that takes a deliberately irritating medicine, usually a high concentration of sugar solution, and injects it into the ligament to try and stimulate the body to lay down new tissue. Sort of like you'd put a piece of sand in an oyster to develop a pearl with that mother of pearl. We can take stem cells from umbilical cords and amniotic fluid, and we can inject those. Now, those are not live stem cells. You do not want someone else's live stem cells. They are dead, but when they break apart, they release chemicals there that act like fertilizers for your own stem cells. And then we can take your blood, spin it down, and take out the platelets. It's called Platelet-Rich Plasma, or PRP. Or we can go to your bone marrow and take out and take out bone marrow and spin that down and take out the platelets. And that's called bone marrow concentrate, or BMC. So lots and lots and lots of things that we can do once we've made the diagnosis of neck pain, and lots of things that we have to have the differential diagnosis, and lots of confusing things where there can be overlap of symptoms, and there's where the interventions help make the diagnosis. Oh, goodness gracious, sorry. So, well, thank you very much with that. And are there any questions?